Whenever you look at the history of critical care medicine, there's this really clear, almost overwhelming instinct that has just dominated the ICU for decades.
Right, the instinct to just intervene,
Yeah.
to do more.
Exactly. Like when a patient's physiology starts to collapse, the mandate has always been to, do more, push more fluids, add another broad spectrum antibiotic.
Stack the vasopressors.
Yeah, flood the system with targeted therapies. We're trained to look at acute systemic infections through this lens of maximalist intervention. It's like we assume a crashing patient requires a kitchen sink approach just to survive.
I mean, that aggressive posture doesn't come out of nowhere. It stems directly from the raw mortality data. Sepsis is, well, it's terrifying.
Right.
We're talking about an acute organ dysfunction triggered by a wildly dysregulated host response to infection. It affects roughly 49 million people globally every single year.
Wow. 49 million.
Yeah, and it claims an estimated 13 million lives annually. To put that burden into context, the in-hospital mortality rate for a patient who develops septic shock is actually way higher than a patient coming in with a massive heart attack.
Wait, really? Higher than a STEMI?
Significantly higher. So when clinicians face a time-sensitive emergency of that magnitude, the psychological and, honestly, the institutional pressure to throw every conceivable pharmaceutical weapon at the patient is immense.
Which brings us to today. Welcome to the deep dive. Whether you are a medical professional auditing the latest shifts in critical care literature, or just a fiercely curious mind tracking how modern medicine evolves under the weight of new data, you are in the exact right place.
Glad to be here for this one. It's a massive topic.
It really is. Today we are dissecting the highly anticipated 2026 Surviving Sepsis Campaign International Guidelines, which were just published in Critical Care Medicine.
And it is a dense document.
Oh, absolutely. We have 129 updated statements synthesized by an international panel of experts. But what stands out to me right away isn't what they're adding to our therapeutic arsenal, it's what they're actively stripping away.
Yeah, that's the real story here.
We're looking at this massive philosophical pivot, moving from more is better to a highly constrained, precision-based model of pharmacotherapy.
The 2026 guidelines really represent a maturation in how we interpret critical care data. I mean, if you trace the lineage back to the early 2000s, the whole era of early goal-directed therapy dictated highly aggressive, protocolized resuscitation.
Right, I remember that. Chasing specific numbers on a monitor.
Exactly. Chasing those numbers with immense volumes of intravenous fluid and, continuous blood transfusions. But over the last several years, the critical care community has finally subjected its own, quote-unquote, common sense interventions to rigorous randomized controlled trials.
And the results of those RCTs have been pretty humbling, right?
Oh, totally humbling. What those trials have consistently revealed is that many of our favorite adjunctive therapies, the things we swore by, either offer zero mortality benefit or actively cause harm.
That's wild. So out of the 129 statements in the 2026 document, I saw that 81 are conditional recommendations.
Yeah, and a striking number explicitly recommend against former staples of care. The focus has shifted decisively toward mitigating iatrogenic harm.
Meaning harm caused by the medical treatment itself.
Exactly, specifically reducing polypharmacy, minimizing ICU-acquired complications, and really combating the global crisis of antimicrobial resistance.
Okay, let's unpack this, because it sounds like we used to treat sepsis like a house fire, right? Just flood the whole block with water.
That's a great analogy.
But now we're realizing the water damage is destroying the houses that didn't even burn. Is it really that hard for medicine to let go of the more is better instinct?
It is incredibly hard, because doing less feels like you're giving up. But medicine is finally acknowledging that every single intervention carries a physiological tax. There is no free lunch in the ICU.
Right. So to understand how this constrained high-precision approach alters the actual minute-to-minute management of a crashing patient, we have to start with the cornerstone of sepsis treatment.
Antimicrobials.
The antibiotic.
Exactly. The 2026 guidelines upgrade extended-infusion beta-lactams to a strong recommendation. And this isn't just some abstract debate over which drug to pull off the shelf, right? It's a fundamental reevaluation of pharmacokinetics.
It really is. So the beta-lactam class, which includes your penicillins, your cephalosporins, carbapenems, they operate on a time-dependent killing mechanism.
Okay, time-dependent. What does that mean in practice?
Well, unlike some other drugs where you just want one massive toxic peak concentration in the blood to shock the bacteria, beta-lactams require endurance.
Ah, okay.
Their efficacy depends almost entirely on the percentage of time the free drug concentration remains above the minimum inhibitory concentration, or the MIC of the target pathogen.
So if the drug level in the blood dips below that MIC threshold, the bacteria just start replicating again. Exactly. You need a continuous presence. But the traditional culture on the hospital ward usually dictates hanging a bag of antibiotics and running it in over, say, 30 minutes.
Right, you give a fast bolus, flush the line, and then you just wait 6 to 8 hours to do it again.
Yeah, and in a healthy outpatient, that works fine. Their kidneys filter the drug out at a predictable rate. But a septic patient is not a predictable pharmacokinetic vessel. Their internal plumbing has fundamentally changed.
Because of the inflammation.
Because of the massive inflammatory cascade, yeah. First, you have the degradation of the endothelial glycocalyx.
Okay, the glycocalyx. That's the delicate gel-like layer of glycoproteins lining the inside of our blood vessels, right?
You got it. Sepsis literally shears this layer off. It destroys the barrier integrity of the capillaries. So fluid, proteins, and the drugs dissolved in that fluid, they all leak out of the intravascular space.
Into the surrounding tissues.
Exactly. In pharmacokinetic terms, the volume of distribution massively expands. So a standard 30-minute bolus of a beta-lactam becomes instantly diluted across this waterlogged, demitous body.
Oh, wow. So the peak concentration drops dramatically because the same milligram dose is suddenly forced to cover a much larger physiological footprint.
Precisely. And on top of that spatial dilution, you have a mechanical filtration problem. The early hyperdynamic phase of sepsis often triggers what we call augmented renal clearance.
Meaning the kidneys are working too fast.
Yeah, driven by this initial surge in cardiac output, the kidneys basically go into overdrive. They filter blood and flush water-soluble drugs out of the body at vastly accelerated rates.
So you combine a massively expanded volume of distribution with augmented renal clearance, giving a 30-minute bolus almost guarantees the patient will spend a dangerous percentage of the day with subtherapeutic drug levels.
Exactly. The bacteria thrive in those troughs. The clinical solution, which the BLING-3 trial definitively tested, is to just change the delivery speed.
Right, the BLING-3 trial, this came out in 2024, right?
Yes, 2024. And by utilizing a continuous or extended infusion, like running the drug slowly over several hours or even continuously over 24 hours, we maintain the serum concentration steadily above that MIC.
So it completely negates the effects of the rapid renal clearance and the capillary leak. Here's where it gets really interesting for you as a listener. Giving a standard bolus in sepsis is basically like trying to fill a leaky bucket with a single splash of water.
It just drains right out.
Yeah, it drains right out. But a continuous infusion is like leaving the hose running on a slow trickle. The bucket actually stays full.
That is exactly what the BLING-3 trial proved. They randomized critically ill patients across over 100 ICUs to receive continuous versus intermittent beta-lactam infusions.
And the results were pretty compelling, right?
They were. Now, the overall mortality difference across the broad heterogeneous population wasn't some massive double-digit reduction, but the subgroup analysis for patients with the most severe illness showed a very compelling mortality benefit signal.
Plus, they proved vastly superior target drug level attainment.
Right. The drug was finally remaining in the therapeutic window. Synthesizing BLING-3 with previous meta-analyses gave the Surviving Sepsis campaign the critical mass of evidence they needed for a strong recommendation.
But logistically, this has to be a nightmare for hospitals.
Oh, it introduces significant operational friction.
I mean, you are permanently occupying an intravenous catheter lumen. You're tying up an electronic infusion pump for 24 hours a day for just one drug.
Yeah, and in a resource-rich academic medical center, that's maybe just an inconvenience. But think about a low-resource hospital or an ER operating at mass casualty capacity.
An insufficient supply of programmable infusion pumps suddenly becomes a hard barrier to evidence-based care.
Absolutely. And there's also the pharmacological reality of drug stability. A drug like piperacillin tazobactam degrades when it's just left hanging in an IV bag at room temperature for extended periods.
So how do the guidelines handle that?
They're highly pragmatic about it. They explicitly acknowledge the complexities of drug compatibility. I mean, you cannot empirically run life-saving vasopressors through the same IV lawn as a continuous beta-lactam without verifying chemical compatibility.
Right, you don't want the drugs crystallizing in the line.
Exactly. But the pharmacokinetic data is so irrefutable that the directive to hospital administrators is to prioritize getting the necessary supplies, multi-lumen central lines, dedicated pumps to make this happen.
We're taking a legacy drug class and optimizing its lethality against pathogens just by altering how we drip it into the vein. It's fascinating.
Is a precision medicine without inventing a new drug.
Okay, so we are maximizing the drugs we definitively need. But the 2026 guidelines apply an even heavier hand to the antimicrobials we do not need, which leads us into the de-escalation mandate.
This is a huge shift in ICU culture.
The document provides a strong recommendation for the immediate de-escalation of antibiotics once a specific pathogen is identified. And they pair that with conditional recommendations explicitly against routine empiric anaerobic coverage and against empiric antifungal coverage.
Yeah, because historically, the inertia of the ICU has always favored broad-spectrum coverage.
Better safe than sorry, basically.
Right. The prevailing fear of missing some covert pathogen leads to these prolonged courses of multi-drug regimens. But the 2026 guidelines dismantle that.
Now, they do still mandate giving broad-spectrum antimicrobials immediately, right? Like within the first hour?
Oh, absolutely, within 1 hour of recognizing septic shock. But they view that initial broad coverage as a temporary high-risk bridge. The moment the cultures come back and the specific pathogen is identified, the standard of care is to rapidly narrow the spectrum of therapy.
Wait, if a patient is crashing, why wouldn't a doctor want to cover every possible bug? I mean, it feels incredibly counterintuitive to hold back on antifungals or anaerobic coverage when someone is literally fighting for their life.
It's rooted in a very human anxiety. I mean, you have a patient who was hovering on the edge of cardiovascular collapse 48 hours ago, and they're finally stabilizing on a cocktail of 3 different antibiotics.
Right.
Pulling 2 of those drugs off the chart feels incredibly risky to the clinician. But maintaining that broad coverage isn't neutral. Those drugs are actively altering the patient's internal ecosystem.
You're talking about collateral damage.
Exactly. Prolonged exposure to broad-spectrum agents induces acute kidney injury, it drives multi-drug-resistant organisms, and it leaves the patient highly vulnerable to devastating secondary opportunistic infections like C. diff.
So let's talk about the recommendation against routine empiric anaerobic coverage.
Anaerobic bacteria thrive in oxygen-depleted environments, and they are undeniably virulent when they cause specific localized infections like deep intra-abdominal abscesses, ischemic bowel, or necrotizing soft tissue infections.
So if a patient comes in with a ruptured appendix, anti-anaerobic coverage is non-negotiable.
Non-negotiable, yes. But if a patient presents with standard community-acquired pneumonia or urosepsis from a UTI, the statistical probability of an anaerobic pathogen driving the systemic shock is exceptionally low.
And giving those strong anti-anaerobic drugs in those scenarios just destroys the gut microbiome.
Completely sabotages it. And in sepsis, the microbiome is a critical defensive organ.
Right, because the healthy anaerobes in the gut produce short-chain fatty acids like butyrate.
Yes. Butyrate is essential for maintaining the tight junctions of the intestinal epithelium.
So when you wipe out those anaerobes with unnecessary antibiotics just to be safe, you destroy the structural integrity of the gut wall. The gut basically becomes permeable.
It becomes leaky. And that permeability allows pathogenic aerobic bacteria, the ones that survive the antibiotic onslaught, to translocate directly across the intestinal barrier and into the bloodstream.
Wow, so you're creating a secondary source of sepsis.
Exactly. Observational studies heavily corroborate this. They show that giving empiric anti-anaerobic drugs to patients without specific risk factors actually correlates with increased mortality.
The intervention itself kills the patient by ruining their mucosal immunity.
Yeah. And the guidelines really reinforce this concept of microbiological preservation through their stance on selective decontamination of the digestive tract, or SDD.
Right, SDD. That's for mechanically ventilated patients in ICUs with low baseline rates of antimicrobial resistance.
Yeah. You apply specific, non-absorbable antimicrobials, usually a paste containing polymyxin E, tobramycin, and amphotericin B, directly to the oropharynx in the stomach.
And the goal there is to eradicate the pathogenic aerobic bacteria that cause ventilator pneumonias while explicitly sparing the commensal anaerobic flora of the gut.
It is a targeted, localized chemical warfare strategy. And meta-analyses show it probably reduces short-term mortality. It proves that preserving the anaerobic bacteria isn't just some abstract stewardship goal, it directly impacts survival.
The era of carpet bombing the patient's microbiome is officially over.
Long over.
Okay, so we've established the precision required to clear the infection itself. But antimicrobials take hours or even days to achieve source control.
Right, and in the interim, the patient is actively dying from hemodynamic collapse.
Exactly. Sepsis initiates profound systemic vasodilation. The pipes just open up entirely and the blood pressure plummets.
Blood stops perfusing the brain, the myocardium, the kidneys. It's the hallmark of septic shock, and it requires immediate mechanical and pharmacological resuscitation.
So the initial intervention remains intravenous fluid, right? The guidelines still suggest giving at least 30 milliliters per kilogram of crystalloid fluid within the first 3 hours.
Yes, because of that capillary leak we talked about. The intravascular tank is effectively empty. We have to increase the venous return to stretch the myocardial fibers, which increases stroke volume and cardiac output.
But the 2026 document heavily emphasizes a biphasic conceptualization of fluid management.
This is crucial. The traditional approach often resulted in days of continuous aggressive fluid loading. Patients would end up massively edematous.
Like, incredibly swollen.
Right. But the guidelines mandate an active pivot from the acute resuscitation phase to an evacuation phase. Once the shock stabilizes, clinicians have to actively employ loop diuretics or ultrafiltration to pull that third-spaced fluid back out of the body.
Because if you don't, that fluid doesn't just sit harmlessly in the tissues, it creates severe interstitial edema.
Exactly. And in encapsulated organs like the kidneys, this fluid accumulation creates a renal compartment syndrome. The hydrostatic pressure literally collapses the capillary beds, halting filtration and inducing kidney injury.
Plus, at the cellular level, that massive swamp of leaked fluid drastically increases the diffusion distance between the capillary and the mitochondria.
Oxygen just cannot traverse that distance efficiently. The cells suffocate even if there's plenty of oxygen in the lungs.
Observational data consistently links cumulative fluid balance, how much water weight the patient retains, with significantly increased ICU mortality.
So we fill the tank initially to prevent cardiovascular collapse, but we must actively drain the swamp days later.
But in profound septic shock, fluid alone is rarely enough. The pipes remain pathologically dilated. We need vasopressor therapy. And the undisputed first-line vasopressor in the 2026 guidelines remains norepinephrine.
Norepinephrine is king, and the rationale is purely rooted in its receptor pharmacology. It has a highly specific affinity for alpha-1 adrenergic receptors, which are densely located in the smooth muscle of the peripheral vasculature.
So when norepinephrine binds to these receptors, it triggers this massive influx of intracellular calcium.
Yeah, the calcium binds the calmodulin, causing the smooth muscle to forcefully contract. It decisively tightens the systemic pipes, elevating the systemic vascular resistance and restoring the mean arterial pressure.
And crucially, norepinephrine achieves this vasoconstriction with minimal stimulation of beta-1 adrenergic receptors.
Right. Beta-1 receptors are mostly in the heart. If you use a vasopressor with heavy beta-1 affinity, like dopamine,
You're essentially whipping a failing heart.
exactly. You force the myocardium to squeeze much harder and beat significantly faster. In a patient already experiencing profound oxidative stress, drastically increasing myocardial oxygen demand frequently provokes lethal tachyarrhythmias.
RCTs comparing norepinephrine directly to dopamine show lower mortality and fewer arrhythmias with norepinephrine.
But while the choice of drug is the same, the 2026 guidelines introduce a massive paradigm shift regarding how we administer it.
The move to peripheral access, this is huge. Historically, central venous access was an absolute prerequisite for infusing potent vasopressors.
Right. The medical dogma dictated that if norepinephrine was infused through a standard 5E in the arm and the phi extravasated, meaning the catheter slipped out of the vein and the drug pooled in the tissue, the vasoconstriction would cause tissue necrosis.
We feared turning a patient's arm black.
Yes. So ERs would routinely withhold life-saving vasopressors until a central venous catheter could be threaded into the internal jugular or subclavian vein.
But placing a central line is a sterile, time-consuming surgical procedure. It requires ultrasound, a highly trained physician, and precious minutes that a hypotensive patient simply does not have.
Which is why the 2026 guidelines issue a conditional recommendation to aggressively alter this timeline. Do not delay vasopressors to secure central access. Start them peripherally immediately.
And this is based on a decade of safety data, right?
Exactly. Large-scale observational studies prove that peripheral administration is overwhelmingly safe, as long as you use a properly placed large-bore IV and monitor the site rigorously.
Because the physiological reality is that the lethal consequence of untreated hypotension, like anoxic brain injury and cardiac arrest, vastly outweighs the statistically rare risk of peripheral tissue necrosis.
And even if extravasation does occur, it can be rapidly reversed using local subcutaneous injections of phentolamine or topical nitroglycerin paste to vasodilate the tissue.
It's a pragmatic shift that democratizes rapid sepsis care. Rural ERs can initiate life-saving resuscitation without waiting for a critical care transport team.
It saves lives by saving time.
So we're tightening the pipes with peripheral norepinephrine. But what happens when you've maxed out that drug and the blood pressure is still dropping?
That's when the vasculature becomes refractory. The receptors downregulate, and we have to utilize a multimodal step-up approach, adding a second vasopressor with a completely different mechanism of action.
Historically, vasopressin was highly favored here.
It makes physiological sense. Septic shock depletes the pituitary's natural stores of endogenous vasopressin. So by giving exogenous vasopressin, you replace a hormone the patient exhausted.
It binds to V1A receptors on the smooth muscle, inducing vasoconstriction through a non-adrenergic pathway, so you can decrease the dose of norepinephrine.
But the 2026 guidelines notably downgraded vasopressin to a conditional recommendation.
Because of the mortality outcomes.
Yeah. The landmark RCTs, the Van Ass trial and the Vanish trial, failed to demonstrate a consistent, statistically significant overall mortality benefit for vasopressin compared to just using norepinephrine alone.
Right. If it doesn't definitively reduce mortality, it gets downgraded.
It's still a valuable catecholamine-sparing adjunct, but it's not a definitive mortality-reducing intervention.
And if both alpha-adrenergic and V1A receptors are maximally stimulated and the patient is still crashing, or if the heart itself starts failing, we bring in epinephrine.
Epinephrine is the highest tier of pharmacological support, potent agonist of both alpha-1 and beta-1 receptors. It provides intense inotropic support, violently forcing the failing myocardium to contract harder.
But the physiological cost is astronomical. Epinephrine drives massive increases in myocardial oxygen consumption.
And it induces intense skeletal muscle aerobic glycolysis via beta-2 receptor stimulation, which floods the bloodstream with lactate.
Which completely confounds the clinician's ability to use lactate clearance as a marker of resuscitation. You can't tell if the patient is improving or just reacting to the drug.
Exactly. Every escalation is a precarious tightrope walk. You trade one profound stress for another.
But all of this aggressive titration begs a foundational question. What exactly is the blood pressure number we are fighting so hard to reach? This brings us to one of the most fascinating age-based shifts in the entire document.
You're talking about the mean arterial pressure targets.
Yes, the MAP targets. MAP represents the time-weighted average of the pressure within the arterial system during a cardiac cycle.
And because the heart spends roughly 2/3 of the cycle in diastole, the relaxation phase, the MAP is a far superior indicator of tissue perfusion than just the systolic blood pressure.
For decades, the universally accepted target for septic shock has been a MAP of 65 millimeters in mercury.
Keep the MAP at or above 65, and the brain and kidneys get adequate perfusion. Let it drop below 65, and you risk acute tubular necrosis.
The 2026 guidelines keep this 65 target for the general adult population, but they introduced a highly specific conditional recommendation targeting adults 65 and older.
Yes, for adults 65 and older, they suggest a lower MAP target of 60 to 65. This is based on the 65 trial from 2020.
And this trial really challenged the assumption that a single, rigid hemodynamic target is appropriate across the entire spectrum of human aging.
Because as we age, our vascular architecture fundamentally changes. We develop arteriosclerosis. The elastin in our arterial walls degrades, replaced by rigid collagen. The vessels stiffen.
So what does this all mean? It's like trying to force high-pressure water through old, brittle plumbing. If you crank the pressure too high, the pipes might burst or you damage the pump. It's actually safer to accept a slightly lower pressure.
That is the perfect analogy. In a clinical setting, forcing an elderly patient with stiff vasculature to achieve a MAP of 65 frequently requires massive, sustained doses of vasopressors. We saturate their receptors with norepinephrine.
And the consequence of those high doses is severe. The catecholamine surge triggers oxidative stress in the myocardium, causing lethal arrhythmias. It shuts down blood supply to the gut or induces digital ischemia.
You get necrotic fingers and toes. The 65 trial hypothesized that the iatrogenic harm caused by the vasopressors was actually eclipsing the theoretical benefit of the higher blood pressure.
So they randomized critically ill patients 65 and older into two cohorts. One got standard care, MAP of 65 or higher. The other got permissive hypotension, targeting a MAP between 60 and 65.
And the results disrupted critical care dogma. The 90-day mortality between the two groups was statistically similar, proving the lower target didn't inherently kill patients.
But crucially, the permissive hypotension cohort had significantly reduced exposure to vasopressor medications.
Which means less arrhythmias, less ischemia. Subsequent meta-analyses actually confirmed that targeting this slightly lower blood pressure reduced overall mortality at the longest follow-up points for this demographic.
The clinical implication is staggering. By religiously treating the monitor by prioritizing a bright green 65 on the screen over the complex physiology of an aging patient, we were inadvertently poisoning older adults with lethal doses of catecholamines.
Exactly. It requires immense clinical maturity to look at a map of 61 on an elderly patient's monitor and actively choose not to increase the vasopressor drip.
Treating the patient, not the parameter.
Always.
We've seen how pulling back on blood pressure targets spares older patients from harm. Now let's look at the ultimate example of pulling back the dramatic fall of the adjunctive vitamins.
Oh, the metabolic resuscitation craze.
The 2026 guidelines issue strong recommendations against the use of adjunctive IV vitamin C and vitamin D.
The trajectory of intravenous vitamins over the last decade is one of the most volatile hype cycles in modern medicine.
A few years ago, the critical care world was obsessed with metabolic resuscitation. The theory for vitamin C was heavily anchored in mitigating oxidative stress.
Right. Sepsis initiates this chaotic inflammatory storm with massive overproduction of reactive oxygen species, free radicals that strip electrons from cellular membranes, destroying the glycocalyx and mitochondrial function.
And ascorbic acid, vitamin C, is a potent electron donor, an antioxidant. So the theory was that massive doses of IV vitamin C would scavenge those free radicals, stabilize the endothelium, and halt the shock.
It makes complete intuitive sense.
It really does. I mean, we're taught from childhood that vitamins are inherently good. Drink your orange juice, get your sunlight. How hard was it for the medical community to accept that these seemingly harmless vitamins were actually killing critically ill patients?
It was incredibly hard to accept. But the scientific method is entirely agnostic to intuition. It demands rigorous, blinded, multi-center validation.
And the definitive turning point was the Lovett trial, published in 2022.
Yes. The Lovett trial, it randomized ICU patients receiving vasopressors to get either high-dose IV vitamin C or a placebo.
And the results were not just neutral. The trial demonstrated a statistically significant increase in the risk of death or persistent organ dysfunction in the vitamin C group.
The intervention actively harmed the patients.
The immediate question is, how does a water-soluble antioxidant induce fatal outcomes?
It lies in the complex, dose-dependent biochemistry of ascorbic acid. When administered in the massive gram-level intravenous doses utilized in these protocols, its behavior fundamentally inverts.
Because of free catalytic metals, right?
Yeah.
Like iron released from damaged red blood cells.
Exactly. In the presence of free iron, high-dose vitamin C actively participates in the Fenton reaction. It reduces the ferric iron, allowing it to react violently with hydrogen peroxide, generating highly toxic hydroxyl radicals.
So the massive dose of the antioxidant actually acts as a potent pro-oxidant. It exacerbates the exact cellular damage it was supposed to prevent.
It's a devastating pharmacological paradox.
Yeah.
But the iatrogenic harm extended far beyond cellular chemistry. High-dose for IV vitamin C directly interfered with the technological hardware used to keep patients alive.
Factitious hyperglycemia.
Yes, this is a critical technological vulnerability. Many point-of-care capillary blood glucose monitors rely on specific enzymatic reactions, like glucose dehydrogenase, to quantify blood sugar. Because the ascorbic acid molecule is a powerful reducing agent and structurally resembles glucose, it aggressively donates electrons to the test strip mediator.
The monitor registers a massive electrical current and falsely interprets it as profound hyperglycemia, displaying blood sugars over 300 or 400.
And the clinical danger there is immediate. A nurse sees a critical alarm, follows protocol, and gives a large bolus of intravenous insulin.
But the patient's actual blood glucose was perfectly normal. So the insulin rapidly drives their true blood sugar into profound, life-threatening hypoglycemia.
Which causes irreversible brain injury, seizures, and death. The Lovett trial researchers had to proactively modify their entire blood glucose monitoring strategy, relying exclusively on central lab testing, just to prevent the trial intervention from causing hypoglycemic fatalities.
Unbelievable. And vitamin D suffered an identical collapse in credibility in the Violet trial.
Yeah, the theory there was also rooted in immune modulation, since critically ill patients are almost universally vitamin D deficient. The Violet trial tested a massive single enteral dose of vitamin D3.
And it showed absolutely zero overall benefit, and a signal for harm, a higher 90-day mortality risk in the sepsis subgroup.
The biological complexity of a dysregulated immune system during sepsis just cannot be fixed. by indiscriminately flooding it with a single prohormone.
The story of the vitamins perfectly encapsulates the 2026 guidelines. A rigorous, almost ruthless commitment to evidence over theoretical hype. But we have to contrast the vitamins with corticosteroids.
Intravenous corticosteroids survived the purge.
They did. Sepsis frequently induces critical illness-related corticosteroid insufficiency. The massive inflammatory storm overworks the adrenal cortex, and it just can't synthesize enough cortisol to maintain vascular tone.
So we administer intravenous hydrocortisone to replace that deficit. But we have to be clear, no one is arguing steroids are a miraculous cure that drops mortality to zero.
The data from the major trials like adrenal and a pro-CHSS show the mortality benefit is nuanced, relatively small, and highly dependent on patient phenotype.
Exactly. But despite that, the guidelines maintain a conditional recommendation for using IV corticosteroids for patients with septic shock requiring ongoing vasopressor therapy
Why retain them if they don't definitively save lives across the board?
because of their undeniable, highly consistent physiological effects on hemodynamics. Across almost every major trial, corticosteroids definitively reduce the time a patient spends in cardiovascular shock.
Because they restore the sensitivity of the alpha-1 adrenergic receptors on the vascular smooth muscle, they make the patient's blood vessels responsive to the norepinephrine again.
Precisely. Clinicians can drastically reduce the dose of norepinephrine and get the patient off vasopressors days earlier. That reduces exposure to ischemic complications and arrhythmias.
Even with the trade-offs like hyperglycemia and hypernatremia, the benefit of rapidly resolving life-threatening shock is deemed worth it.
It's the perfect distillation of the document's philosophy, the messy clinical reality of steroids over the alluring biological hype of vitamins.
So to synthesize this incredible journey, the 2026 Surviving Sepsis Campaign Guidelines are a masterclass in precision. From continuous infusions in the BLING-3 trial to age-specific MAP targets to the active de-escalation of antibiotics and the total abandonment of unproven vitamins.
The era of throw everything at it is officially over.
Why should you, the listener, care? Because this document represents how the scientific method corrects itself. It's a testament to the fact that doing less but doing it smarter is the future of complex problem solving, whether in the ICU, in business, or in life. Blind action is not a substitute for accurate data.
It requires profound courage to actively choose to do less when the stakes are highest.
It really does. And I'll leave you with a final thought to mull over. If the 2026 guidelines are all about narrowing down treatments based on large group trials, what happens in 2030 or 2035? Will we abandon broad guidelines entirely? Imagine a world where artificial intelligence analyzes your specific genetic makeup and the real-time molecular signature of your infection, creating a completely bespoke N-of-1 protocol just for you. We are moving from the shotgun to the sniper rifle. But soon, we might be using heat-seeking missiles.
Until that technology arrives, we must strictly adhere to the evidence we have painstakingly acquired.
Sepsis remains incredibly chaotic. But if we rigorously test our assumptions and have the courage to strip away interventions that do not work, we can illuminate a clear path forward. Until next time, keep diving deep.